So hello everyone. So today what we're going to do is do some dry massage techniques for the lumbar area, the hips, the glutes, and the high adductors. Now those are a lot of the areas that the athletes that we see address compared to seeing them in a clinic setting. So Jillian is also part of the CSMTA and she'll be my body. And so we're going to go through different positions and using dry techniques. Okay. So we'll first off start in a seated position, because what I want to do is work on the lumbar area as well as the QL area. Okay. Oh, sorry? Nope, you're good. There we go. So what I like to do first, instead of them being lying on the table, either prone or supine, is I get them in a seated position, and I like to use moving their body while I treat. So what I'm going to do is I'm going to use my palm of my hand on the lumbar erectors and then the QL. My other hand is going to be doing half a hug on Jillian and moving her in a sideline position and a rotating position. So if I can have you cross your hands over your shoulder for me. Perfect. So I have my palm on the lumbar area. And then from there, I'm going to side bend Jillian, and I'm going to compress on the lumbar erectors, and then rotate Jillian using still my palm. And then afterwards, I'll start using my thumb. So with my thumb, it's a downward pressure. And then I work more on the lateral aspect of the lumbar erectors and then onto the QL. Is that pressure okay? And then from there, still have my palm or my thumb on the lumbar erectors, and I lean forward with Jillian, making sure my body mechanics is sound, and having my knee on the table helps me with that. Good. And then from there, I'm going to ask Jillian to lie on her side, because at this point, we're going to work on the QL, lumbar erectors, and the side of the hips. So if I can have you lie on your side facing me. Going to lift up the table. Oh, there we go. So you also have a pillow underneath the waist, so that will bring up the QL. And what I like to do is have my thumbs reinforced, and I'm going to work on the anterior aspect of the QL. And then from there, sink my fingers in and then slowly move posteriorly. Is that okay? And then what I'm going to do is a little bit of what I call nudging. I'm going into the tissue and then release. Instead of going in there and starting digging, you may have a protective mechanism. So it's going to be more of a little bit of a nudge getting into that area. And then moving superiorly to its attachment on the ribs. And then inferiorly towards the iliac crest. After I finish that, then I can work on the lateral side of the hips. So you got glute med and min, you got the TFL in this area. What I like to do is use my elbows. And so I stabilize the hip area, use my olecranon. So I palpate the greater trochanter, move superiorly from there, and then slowly sink into glute medius, and then move side to side, and then cross fiber. With fiber and then cross fiber. Gentle compression first, because again, they may be protective. And then move superiorly towards the iliac crest. And then continue doing side to side motions as a cross fiber from glute medius and then towards TFL. And then along TFL, do the same type of motion towards its attachment on the IT band. And what I find, there's certain areas on the low back, the hip area, that get adhered, so superficial adhesions, and that's where I want to work a little bit more on. So with a greater trochanter, you got glute med and min coming down, you got TFL and anterior aspect, and then glute max on the other aspect. So all along around the greater trochanter, it can feel adhered. So what I like to do, I'm going to show it in this position and then in the opposite position, is I get my elbow or my fingers and what I call shaving off. So basically I'm around the greater trochanter, not on it, but around the periphery, and then just do cross fiber, and then even static rotation along the muscles that attach to the greater trochanter area. Like that. Good. And now I'm going to turn, have Jillian look towards the audience. Good. Your head there. Now in this position, while I'm in the back, I'm going to work on the posterior aspect of glute medius, as well as glute maximus as well in that area. So same type of hand position, so you can use your elbows or your fingers. So I'll start with my elbow, working on the posterior aspect of greater trochanter. Again, using that shaving off technique, either cross fiber or with circular motion. As I move inferiorly, you're going to get into the distal attachment of glute max on glute tuberosity, as well as attachment on the IT band. And then in this position, staying with the glutes, I could go to the attachment of glute max. So it's anterior to PSIS and along the lateral part of the sacrum. Again, cross fiber and circular motion. And then on the muscle belly itself. Is that pressure okay, Jillian? And then I move from the glutes towards the lumbar erectors and the QL in this position. So instead of using my thumbs, now I'm going to use either my elbow into this area. So again, having a pillow underneath. Slowly move in to the QL area and the lumbar erectors. So I'm going with fiber and then cross fiber. After I've addressed that area, I'm going to move superiorly onto the ribs. The reason why is you got the latissimus dorsi turning into the thoracolumbar fascia, attaching to the sacrum and the ligaments on the posterior S-side ligaments. So in this particular case, I'm working on latissimus dorsi on its attachment on the ribs. I'm going cross fiber. And then you can also have the arm above the head to help lengthen the lumbar erectors and continue doing that motion. Thank you. Now we're going to move in in a prone position. So in the prone position, what I find that another area that gets adhered is superficial to the sacrum, because you have the thoracolumbar fascia, you have the multifidi moving onto the sacrum, you got the posterior S-side ligaments, all conjoining into that area. So what I find is working on the athletes in that area helps free up the hip area along with treating the lumbar area. So with that in mind, in terms of landmarking, you palpate the PSISs. You know that that's basically the level of S2. So you palpate S2, the spinous process, and you know that along the spinous process is the midline of that area. So I like to work on either side of the spinous processes of the sacrum as well as the PSIS, because that's where a lot of attachment is. And then I work in between PSIS and the spinous processes. So with that in mind, I could do like a pincer grasp, reinforce on either side of the spinous processes, just before the coccyx. Either that, or I could use my thumb, basically the radial border of my thumb, reinforce, and I'm on the ipsilateral side of the spinous processes. So that would be cross fiber. And then in terms of the PSIS, I could either work ipsilaterally or contralaterally using the same hand contact using my thumb. You could use reinforced fingers. You could use your knuckles, so using your pips. And you can also use your elbow. With your elbow, because the bone is very superficial, light pressure first sink into the tissue. My other hand is on the table to stabilize my body. And I'm working with fiber, cross fiber, and circular motion. And in this position, you could do a little bit of joint mobs. So my palm is on the PSIS, rotate the leg laterally to engage, and then doing anterior glide and oblique line, just to create some motion on the SI joint. And then from there, another area that gets a bit adhered is around the quadratus femoris. So quadratus femoris is located between the inferior lateral angle and that's located ischial tuberosity and greater trochanter. So I palpate greater trochanter and ischial tuberosity. And in between those bony structures is quadratus femoris. It has exact same action as piriformis, but there's times where therapists overlook quadratus femoris and only concentrate on piriformis. The sciatic nerve lies deep to quadratus femoris, so you may get some relief if there's any sciatic issue coming from the gluteals rather than the low back area. So with that in mind, you can use your fingers or your elbows with that. So I'm going to first use my fingers. I palpate greater trochanter, palpate ischial tuberosity, and then I move cross fiber from the greater trochanter, and then after a few strokes, I move towards the ischial tuberosity. To have a little bit of what they call like pin and stretch or active myofascial release, I use my elbow in that same area close to the greater trochanter, and as I internally rotate the leg, I apply pressure into quadratus femoris. Is that pressure okay? Okay. And one more area before I turn Jillian supine is the sacral tuberous ligament. With glute max attachment, there's quite a few therapists that forget to also address the sacral tuberous ligament. So the distal attachment are part of the attachment of glute max. So in order to palpate that, you palpate the lateral sacrum inferiorly until you feel the inferior lateral angle. So before it curves in towards the coccyx, palpate ischial tuberosity, and then there's that ligament. So with that, then you could address either using your fingertips or your elbows. So in this particular case, I'll use my elbow, moving from ischial tuberosity, moving cross fiber along that ligament where the glute max attached to the inferior lateral angle of the sacrum. And then afterwards, I'll turn Jillian supine for me. Now, what I'm going to do is address Jillian's lower abdominal. So I'm going to treat just superior to the pubic bone. I'm going to treat close to the adductor attachments, as well as where rectus femoris, TFL, and sartorius converge. I find that that's another area where there's a lot of adhesions in that aspect. So first, what I'm going to do is work on the lower abdominal as well as iliacus. So with that in mind, I'm going to palpate the pubic bone using my palm moving inferiorly. I feel the pubic bone, and then from there, you can use fingers to move cross fiber along the rectus abdominis. I like to use my elbows. So in that particular case, I palpate the pubic bone, have my elbow, olecranon process in there, and I slowly sink in with their breathing. And then I go cross fiber along the lower attachment of rectus abdominis. Then from there, I will move laterally towards the iliac, towards ASIS. And then from there, I'm using the medial aspect of my olecranon to move into the iliac fossa where iliacus is located. So I work with Jillian's breathing, sink in, and now I'm using the medial aspect of my olecranon process to make contact with iliacus, and I'm moving superior and inferior to have a cross fiber direction. And then from there, continue to move along the iliac crest. And then back down. Okay. Good. The next aspect is the TFL, sartorius, and rectus femoris. That's where I find, again, another adhesion area. With that in mind, you could bend the knee, palpate ASIS, and from ASIS, just move a little bit laterally, and then you're on TFL. So I'm on the anterior border of TFL, have my thumb hooked in that position. Leave my thumb stationary, and then I just rotate the leg, medial and lateral. So it's a cross fiber, but leaving my thumb stationary. And then I move slightly inferior along the TFL on the anterior aspect. With rectus femoris and sartorius, I'll use my fingertips, and eventually I'll use my elbow. So I'll palpate ASIS, moving inframedially to AIS, that's where rectus femoris attaches. And then also with ASIS on the medial aspect, that's where sartorius attaches as well. So that little area gets what I call kind of gunked up. So that's the anatomical terminology for that. So what you're gonna do is you're gonna do some fingertip kneading, some dry circular motion. And then from there, you could use your elbow. And then I could rotate the leg to do some cross fiber on rectus femoris. And then I could do with fiber with my olecranon. That way. Now, before I go to sartorius, I just kind of want to roll back to TFL. As you know, with TFL, it attaches to the IT band, just inferior to around the greater trochanter area. But what I found is that because of its attachment to the TFL, it got a little bit of vastus lateralis being involved as well, because IT band sits on top of vastus lateralis. So with that in mind, I palpate the TFL inferiorly into its attachment onto the IT band. And what I'm going to do is I'm going to use the thenar eminence, place it anterior to the TFL, and then I'm going to do medial rotation of the leg. And as I do medial rotation of the leg, I'm pressing posteriorly. So that will create a little bit of disassociation from the TFL vastus lateralis. So you can replace the thenar eminence with your thumb for more specific work, or again, getting back to my olecranon process. With sartorius, I'm going to abduct Jillian's leg, palpate sartorius, and with sartorius, I'm going to do cross fiber with my fingers in line with each other. Is that okay? And then move inferiorly. So you can't see it from the camera here, but I have my thumbs on the lateral aspect as a pivot point. So as I'm pivoting, I'm moving backward towards myself to work cross fiber on the sartorius. And you can use that motion towards the knee as well. Now I'm going to move towards the growing area, so adductor longus, brevis, as well as magnus. And then with that in mind, the leg is already abducted. I'm going to palpate the pubic bone area. So I've palpated the pubic bone. I move off of the pubic symphysis and I move posteriorly and inferiorly. And the first muscle is adductor longus. It's a ropey cord. Is that okay? And then from there, I'm going to hook my fingers posteriorly to adductor longus and move with fiber and then cross fiber. And then move inferiorly to continue working adductor longus. As I abduct the leg just a little bit more, thank you. I go from adductor longus, curl my fingers posteriorly, and then I make contact with adductor brevis. Same type of hand motion with fiber and then with cross fiber. Nice and slow, because athletes are a bit useless because we're continuously working, but when you get clients coming in and this is your first time working on them, you want to go gentle. And then move inferiorly. Now I'm going to work on adductor. You can still work in this position. You can still have the leg in an external, like a figure 4 position. But what I like to do, I'll have a pillow and a towel. I'm going to bring Jillian's foot onto my outside hip area. So what I'm going to do is have a hand to support her knee. My other hand is on her opposite leg to stabilize. And I'm going to move my hip forward, and that'll be a hip flexion with the leg in abduction. That will cause a stretch in the adductor muscles. So I'm going to just start off with passive range of motion. And then I'll gently apply pressure on the medial knee to increase abduction. Nice and slow. All good. And then what I'm going to do is use my palm as medial as possible to adductor longus and adductor brevis and magnus. And then I leave my palm stationary and move my leg while my hand is stationary. Then what I do is I move inferiorly along the muscle. I have my hand making contact with adductor magnus and the other adductor muscles. And as I bring the leg downward, I'm pressing upward. So it's doing a little bit of like an S or C bowing on the muscle. Now what we could also do is using your forearms, not your Lecanon process this time, but the distal third of your forearm. You replace your palm with your ulnar, leave my forearm stationary, and then just move the leg. And then either do that or leave the leg stationary and do cross fiber with my forearm. Or you could alternate doing cross fiber with the forearm while the leg is in motion. So I'm using my hips to move Jillian's leg. Then from there, I have gracilis here as well and adductor magnus. And what I like to do is a pincer grasp. I have my fingers on the anterior aspect of gracilis, my thumb around adductor magnus, posterior aspect of gracilis, and I flex the hip. And as I flex the hip, it's almost again like a pin and stretch. And then I could just use my thumb on the posterior aspect for gracilis as well as adductor magnus. Now, another area that gets adhered is as when the adductor magnus kind of hides distally, and you got vastus medialis and biceps femoris converging. This is another sticky area. So my thumb is located on the distal aspect, and what I'm going to do is with my foot, with Dylan's foot on my thigh, I'm going to stick up my thigh to be knee extension. And that will be like another pin and stretch type of motion. So again, it could be gentle. Once they get used to it, you could also use your elbow into that area. And then the last part is where adductor magnus attaches to. It attaches on the medial aspect of the ischial tuberosity and moving on the ramus. So I'm going to palpate ischial tuberosity. And then just medial to that, I have hand contact with adductor magnus. And I'm going to flex the hip and apply pressure on adductor magnus. And then after a while, move anteriorly and superiorly to capture as much adductor magnus as possible. And then afterwards, I use my elbow on adductor magnus. As I flex the hip, I apply pressure. So another form of pin and stretch or active myofascial release. And then you can either also leave it stationary and then do with fiber or cross fiber. And then you ended it off with some range of motion of the leg. So flexion, extension, rotation, and circumduction. And those are the techniques that you can use dry with the low back, the hips, the pelvis, and the high groin area. And this can be used in a clinic setting. Again, we use this a lot with the athletes, but not as much in a clinical setting, especially with having the leg on your thigh. So that's where, the client consent for sensitive areas will come in effect because you're treating the groin area. So that comes into play. Yeah. Yep, so the towel will be over the foot, and then I'll have a pillow, and it'll be in this area here. In terms of draping, I prefer the athletes or the clients to have shorts, because then like with draping, you're always fussing. So I have a pair of shorts in the clinic area so that they can wear that, and then they feel comfortable enough, because if you have a drape and they feel the breeze as you're moving your leg this way, they don't feel comfortable. So that's why I have the shorts. Yeah. Good. Any other questions? Yeah. Yes. Oh, most definitely. So I've created my own based on the CMTO standard. I made it even more specific because I'm getting into the ligaments on that aspect and the pelvic floor. So I added that in as well. And so we talk about that, and then they sign off. Sometimes what I do is, I talk about it first, they agree to it, and then there's times where I forget and they sign afterwards. And sometimes I like that better because they've gone through that, so they signed the form. I know technically you're supposed to do that before. There's times where I forgot in doing that. Sorry? Yeah, exactly. So definitely that comes into play with athletes that I treat. Even though that's all the things that they want all the time, they just come in and sign because they know that they're going to be treated that way. Things like that. Yeah. Good. Any other questions? Awesome. Thank you so much. Thank you.